Well, good evening. If everyone would take a seat. It's a pleasure to welcome all of you to the first lecture in the 2010-2011 Leading Voices in Public Health lecture series. For those of you who don't know me, I'm Randy Wyckoff, the Dean of the College of Public Health. As you all know, this is ETSU's centennial year, and we have a theme, Partnerships, Promise, and Hope. And we are trying to reflect that theme in this year's Leading Voices series, particularly the issue of partnerships. What you're going to see this year is we're trying to bring in folks from a variety of different disciplines to really talk to us about what we have to learn from each other. So we have a lawyer, we have a mathematician, we have a diplomat, we have a university research scientist, we have a professional actor and a professional storyteller, and the series isn't complete yet. So really the idea about this whole series this year is, what can we learn from each other? What can we learn that will make health better for everyone? And I think tonight's speaker is a great example of someone who crosses multiple disciplines, and the person who's going to introduce tonight's speaker is someone I think we all recognize is a true builder of partnerships within the university, partnerships between the university and the community, and partnerships between disciplines, and someone who I think we are all deeply proud to be a part of an organization that has him as our president. So please join me in welcoming ETSU's president, Dr. Paul Stanton.
Thank you, Dr. Wyckoff. Good evening. It is truly let me turn this just a little, I'm sorry. It's truly a pleasure to welcome a very special individual here tonight as our first lecturer of the 2010-2011 Leading Voices in Public Health series. I've been invited to introduce a number of our speakers over the last few years, but this one is a good friend. I've known Scott Wallace for several years. He and I have served together on the Blue Cross Blue Shield board here in Tennessee. And what I want to tell you is that of all the people I have met in my life, if I were to rank or rate what I would consider the top 10 brightest and most intellectual people and those that I admire the most, Mr. Wallace would be one of those. And I've met a lot of people. I came to appreciate him, as I say, on the board of Blue Cross, but what he's done, what he's accomplished over his years in public service and in business and in other endeavors is truly remarkable. He graduated a couple of times from the University of Chicago. And I don't know how many of you are familiar with the University of Chicago, but it's one of the most prestigious universities in this country. He was trained as a lawyer, and he went on to get an MBA degree. But he's been involved in a diverse field of endeavors. He served as the CEO of a wireless products company, CEO of an advanced materials and chemical company. He was the first president and CEO of the National Alliance for Health Information Technology, a group created by industry leaders. The Alliance really helped to usher in the current enthusiasm and the era of health information technology that we are beginning to enjoy today. And in October 2004, a mere 6 years ago, Mr. Wallace was appointed by the President of the United States, George W. Bush, to be the chair of the Commission on Systemic Interoperability, a commission created by Congress, I think some 11 or 12 strong members, to develop a national health information technology strategic plan. Scott is currently a visiting professor at another very prestigious university. He's a Batten Fellow at the University of Virginia's Darden School of Business. His research focuses on the role of employers in the health of their employees and on redefining chronic disease care. developing new methodologies, and stopping the progression of those chronic diseases. He'll speak to us tonight on improving the value in healthcare, capabilities, and chronic health and health strategy. Truly a pleasure, Scott, to welcome you to the podium. Let's join a round of applause.
Thank you. Okay, now I got that off. I don't generally work from notes, but I've never been introduced by Dr. Stanton, and I want to respond. You all know Paul. Many of you know him well and for a long time. I want to bring you another perspective on Paul, that of somebody from Chicago and who spent a lot of time in Washington. Paul is a Southern gentleman in the best traditions of both of those words. One knows immediately from his drawl and from the omnipresent suspenders that he is in fact Southern. He exhibits those timeless characteristics of the South: concern for and civility toward those he encounters. In an increasingly rushed and indifferent world, he is unhurried, caring, genuinely interested. Wherever he goes, he shares just an unabashed pride in this institution, in its faculty, in this community, and in particular, what Paul always refers to as his students. All 15,000, I believe, are individually his. And like the best men of the South, he is quietly humble. I've never once heard him mention his own role or his contribution in anything that he's done. President Stanton is as well a gentleman. He is a learned man, a scholar, a scientist, a healer. He is a committed spouse, a loving father, and an adoring grandfather. If you don't have 15 minutes, don't bring up the phrase grandchildren. One of the things that I've noticed about Paul is that he lives his faith with a very strong faith in a life well lived, and that's a rare, rare trait. It's an honor absolutely beyond measure to be here to speak to Paul, to his institution and his community. So thank you. Enough notes. Find the clicker and get a drink, sorry. All right. I'm going to step off of here under my own control, because if I try to speak from this place, I will inevitably fall off, and that'll look really funny. As Paul mentioned, this is the theme. I'll kind of lay out four big concepts that I want to go through. The first is this notion of value. It's not a phrase that has been used very much or very long in healthcare. It was first introduced in a broad healthcare context in 2006 when my two colleagues, Elizabeth Teisberg at the University of Virginia and Michael E. Porter at Harvard, published Redefining Healthcare and included value in the title of it. And there was a big debate at Harvard about whether you could put value in the title of a book. Mike thought about it for a while, and he said, tell you what, we're going to leave it in the title. If the book is successful, everyone will start to talk about value, and if the book isn't successful, it really won't have mattered. Interestingly enough, in the entire healthcare debate over the last couple of years, the word value has come up over and over and over and over. I think that they've really changed the way people see that concept. Oops, wrong button. Chronic health is my framing of what a lot of people talk about as chronic disease. I think we have to switch the framing on that, and we have to start thinking about how do we always live healthy? How do we combat these diseases? How do we go from primary prevention, which has always been the goal of public health, to secondary prevention? One has this condition. How do we keep it from getting worse? How do we keep you from losing a foot? How do we keep you from declining more rapidly as a result of coronary artery disease or diabetes or another chronic condition? I'll talk a lot about this idea called capabilities, and I'll wait till I get in there, but the framing on that is that in healthcare we talk a lot about compliance, and I think it's the wrong thing. People are focused on their own capabilities, and that's how we can change the paradigm toward chronic health. And then finally, I'm a business school prof, and strategy is everything. And in healthcare, we have lots and lots of strategic plans. Every hospital has one. It's about as thick as the phone book. But very few healthcare providers, very few institutions, very few health plans really have a strategy. And so I'll tell you a little bit about how to think about the idea of strategy and how to maybe apply that in healthcare. All right, so what are the challenges in healthcare? And I think this is a pretty well-known list that everybody is aware of. Since the IOM report came out in 2001, we recognize healthcare as very error-prone. I remember when that report first came out laughing a lot because there was a huge debate. I don't know if you remember when this came out, the IOM put out a report that said we kill 100,000 people a year as a result of preventable errors in healthcare. And a large part of the medical establishment stood up and said, that's just wrong. The number is really closer to 70,000. And I thought, wow, we've really got an issue. If it's 2, we've got a real issue. Preventable errors are really something that we should be preventing. Healthcare is prodigiously inefficient. We waste huge amounts of money in healthcare. It's ineffective. We don't get the health results that we're spending all this money to get. And another aspect of it is healthcare is really inconvenient. When Randy and I were driving around today, we came past McDonald's. And I said, you know, if we are in the business of health, McDonald's is our competition. And if you think about the convenience and the solution that McDonald's offers, they can give you 5,000 calories in less than 10 minutes for under $5, and you don't have to get out of your car. You want to get something in healthcare? Make an appointment. We'll see you 3 weeks from Thursday. Show up at 11. If the doc's not there by 12, you can leave at 1. You'll probably have to come back in a week anyway. We do everything to make it inconvenient and almost nothing to make it convenient. And then we wonder why it doesn't work in a chronic context. So these are really big problems, and the answer is we have to be able to do this better. Healthcare attracts some of the best and the brightest and the most caring people who are working in a system that's structured poorly and gives them, as a result, frustration and bad results. So let's think about how is it that we do something better. In the work that Elizabeth and Mike did, they determined the root cause of problems in healthcare really had to do with the area of competition. In the US system, we compete to shift costs. Think about that for a second and think about any other industry that you can think of. In healthcare, what we do is we try to make sure somebody else has the responsibility, somebody else is going to have to pay. So hospitals discharge patients as quickly as they can. Whether they bounce back out of the nursing home, well, that's, we'll deal with that later. Insurance plans play this game about who's going to pay which and how much are we going to pay doctors. And everybody's playing this constant game of shifting cost around. And so the competition is in the wrong direction. It's zero-sum competition. It's actually negative-sum competition because shifting all those costs around all that way only runs up the total cost of healthcare. And so what we need to do is we need to shift out of this zero-sum competition And we need to shift toward competition around creating value. And it's not a real strange concept. If you think about almost every other sector of our economy, competition occurs around creating more value. I like to think of the example of web browsers. When I first started doing web browsing, I had a choice of exactly one web browser. It was pretty crummy and it didn't do a lot. And I had to pay for it, $249. I remember clearly. Now there are at least 5 really good web browsers that you can get for free. They do everything other than wash your dishes, and Google apparently yesterday announced that their browser will now wash your dishes. It's all competition about creating value, and we benefit. So in healthcare, we have to start thinking about how do we create value. And in order to do that, we first have to think about what is value in healthcare. The observation that Elizabeth and Mike made is that value is the improvement in health outcomes for the money that we spend. Now, one problem of thinking about value in healthcare is that we don't measure improvements in health outcomes. We don't know how did we do. A fun thing, physicians in the room, including Dr. Stanton, forgive me, but this is a really fun thing to do with your doctor. And there aren't a lot of those that you can really point to, so take notes on this, it matters. Next time you go into your physician, ask him or her, are you good? Let me ask you guys. This is kind of a fun experiment. Usually I ask people to close their eyes, but I'll let you guys keep your eyes open. If you think that your doctor is above average, raise your hand. Oh, you guys are a little more skeptical than most. Most places everybody raises their hand, and we have Lake Wobegon medicine where all the doctors are above average. But the question that comes up is, are you good or not? And most doctors say, well, I went to ETSU. And I said, well, okay, you're very well educated. Are you good? And they don't know because they don't measure the outcomes of what they do. And if you don't measure it, you can't improve it because you don't know what improvement is unless you have some baseline. So one of the really important things that we have to start doing in American healthcare is measuring health outcomes. Did you do it better? Did your patient get better as a result of what you did on their behalf? Now, a question comes up, well, we're not sure how to measure outcomes in X. Toby Cosgrove, the chairman of the Cleveland Clinic, is a world-renowned heart surgeon and instituted a tremendously effective program of outcomes measurement at the Cleveland Clinic. And he said when he first started, the dermatologist said, well, how do we measure outcomes in dermatology? And Toby said, I don't know, I'm a heart surgeon. But if you're a dermatologist, you should know if you're good. How do you know if you're good? Start to measure it. Figure out, are you making patients better as a result of what you do? The money spent, we're good at tracking the money spent. I mean, we bill right down to the individual aspirin in hospitals. We can track the money spent. What we don't know is what are we getting for it. And so what we have to, if we're going to think about creating value, we have to start measuring outcomes to do it. Now, to really improve value requires that we redefine care delivery. And that's what I'm going to spend a lot of this talk talking about, is how do we think about what we do in care delivery to improve value. This issue has tremendous relevance right now. We have passed a health reform bill. We will increase coverage for at least 25 million people, hopefully more than that. And the question that comes up as you start to think about that are, what are our options with expanded coverage? And if you think back to the political debate that occurred, it happened on two polls. One was, I keep hitting the wrong button on this. The first was, we're going to spend more money. We're going to put 25 million more people or 40 million more people, and oh my gosh, we are going to spend so much money. We can't possibly afford this. And then everybody was watching what were the CBOE scores going to be. Who knew what a CBOE score was 3 years ago? Like 3% of the population, they were all geeks. Now everybody knows what a CBOE score is because it came out because we were worried we're going to spend so much more money. The other was, no, what we're going to have to do is really ration care. So there was all this discussion about we won't include this and we won't include that. It was a rationing discussion. We are not going to include as care all these different things. And those were the two choices. We were either going to have to spend a lot or we were going to tell a whole bunch of people you can't get the kind of care that you want to get. What if there's another choice? What if we start to improve healthcare value? Now we're all of a sudden getting something more for what we're spending. And if we improve value, we can cover a whole lot more people without having to spend a whole lot more. This never came up in the discussion. And one of the big failings of the healthcare reform bill is that it's not healthcare delivery reform. The president was very explicit early on. It's health insurance reform. But pretty quickly, in the case of Massachusetts, it took about 16 months. Pretty quickly, we're going to get to a point where we're going to have to think about how do we redefine care delivery because we're going to have to get more value out of what we're spending. So the challenge is how do we improve value? And the answer is you can improve outcomes in ways that reduce cost. And one of the big problems in healthcare is that we've approached this issue wrong. We've started saying we need to reduce cost. We're going to take waste out of the system. Now, if you spend 4 years in medical school and 4 years in a residency and 3 years after that in a fellowship, do you want to be a waste manager? Is that your career aspiration? Improving outcomes isn't all about waste reduction. It's actually about doing things in a way that make people better, recognizing that people who live healthy are cheaper. Good outcomes are less expensive. So here are a couple of examples, and those of you in the back will have a hard time reading this, but this is a list of all of the things, the benefits that you get by improving outcomes. And if you think about stroke care, stroke is the leading cause of disability expense in the US. Patient who has a stroke will incur something close to $300,000 of disability expense in their lifetime. Big, big number. But if we can treat the stroke early, we can often completely eliminate all of those downstream symptoms. So if we do it right, we get the right treatment to the right patient, we get a more complete recovery, less disability, less need for long-term care. It's a better outcome that ultimately saved us a vast amount of money. Same thing happens in diagnosis. If you get the wrong diagnosis for a patient, everything that you've done is waste. And it's dangerous, and it's expensive, and it's uncomfortable, and it's risky. So why don't we focus on how do we get to the right diagnosis first? If we get the right diagnosis, we get a lot earlier treatment, we get the right treatment to the right people, all of a sudden the system works better. And it's not about reducing waste. It's about doing a better job, being a better set of professionals as caregivers. So if we're going to do that, we have to redefine the care delivery system around improving health. And that sounds sort of silly when you say it out loud, but a lot of what healthcare does is not actually geared around improving the health of a patient. So if we shift our focus from all the other things that we do in healthcare and we stop and we say, how can we improve the health of this patient? We will have changed the way that we deliver care. One of the big risks, I think, in the specialty care system that we've evolved in the US is that there's no one responsible for the health of that one patient. I have a very close friend who has a very, very sick child. And they have, over the course of 3 years, seen something like 25 specialists. And each of the specialists says, now please describe your symptoms and tell me what's going on and da-da-da-da-da. And then what they say is, well, you don't fit in my box. Well, they get up and they trudge out and they go home and they try to figure out what's the next specialist they see. That didn't do any good. No one was focused on the health of that individual. And so if we're going to make this thing better, we have to start structuring care around health, improving health outcomes. Right now, if you think about the goal of the current system, it's treatment. Everything that we have is structured around doing things to patients and measuring the increment of what we've done. If we're going to redefine care delivery, we have to change it so that our goal becomes health. Did we improve the health of the patient? If not, you're a failure. Flat out, hate to break it to you, you are a failure. If your patient's health didn't improve, your role in the healthcare system was not met. Flat out. Now, one thing that comes up a lot in the discussion, and it came up a lot in the health reform debate, was this notion that patients want all the health care that they can get. And one reason we need to put in rationing is because patients are just going to use up health care if we don't. And part of the problem is we think about health care as one word. Now, I think that's a wrong perception, and I think I can convince you that that's a wrong perception with a single question. Have you, or do you even know anybody, I'll go broader, do you even know of anyone who knows anybody who's ever checked themselves into the hospital or gone to a doctor's appointment for fun? Do you check into the hospital for relaxation? Great hotels face zero competition from really big hospitals because no one really wants to go there. People aren't seeking more treatment. What people are doing is they're seeking better health. And they've conflated those two ideas. They associate treatment with health because one reason for that is we use this word healthcare as one word. So I think what we should do is make sure we use it as two words. If you use it as one word, it means treatment. If you use it as two words, it means health, which is a state of being. It's what we all wish for, what we all aspire to. And care, which is what we go get when our health is threatened or is failing. But if you put it together as one word, then you only think about treatment, and then you think about patients only want more treatment. But they really don't. Dartmouth, for those of you who are clinical and study this, Dartmouth has proved this clearly and unequivocally. Patients choose less invasive, less expensive treatments over more invasive, more expensive treatments. That seems fairly intuitive. Who wants to get a shot? Who wants to have surgery? Not a lot of people. So think about healthcare as two words, and think about how do we focus on the health of people and give them care when their health is threatened. Okay, so let's think a little bit about chronic conditions and chronic disease. A couple of sort of level-setting facts for you on this. Chronic diseases are the leading causes of death, not just in the US, but in most of the world. Once we got past accidents and infectious diseases and we tamped all that down, chronic disease became the leading cause of death. And it's true in this community, it's true in just about every other community I've ever been in. Diabetes, heart disease, asthma, COPD, I mean, you guys know the list. Chronic diseases and their acute manifestations account for 3/4 of all healthcare spending. 75% of the money that we're spending is for chronic disease. So back to the point that I was mentioning at the very beginning, we need to think in terms of public health, not simply about primary prevention, but about secondary prevention. Once a patient has CAD, how do we keep them from getting worse? If we have a patient who has COPD, how do we keep them from having to bounce in and out of the emergency room all the time? Another characteristic of chronic disease is that it's kind of like a potato chip. It's really hard to have just one. About half of the people with chronic diseases have more than one. About 10% of the people with chronic diseases have 4 or more. There are actually about 5% who have more than 6. I didn't know you could have 6 chronic. I thought you kind of ran out of organs that could be affected. But apparently it can be really bad. Interestingly enough, 4% of Medicaid patients account for 50% of Medicaid spending. So you've heard of the 80-20 rule. We have the 4-50 rule. 4% of Medicaid patients account for about 50% of Medicaid spending. And almost all of that is chronic conditions. One of the big drivers of this is that acute conditions are becoming chronic. AIDS is a great example. AIDS was a death sentence 20 years ago. AIDS is now a chronic condition for most of the people who get that disease. Breast cancer, similar situation. 25 years ago, it was nearly always fatal within 5 years. Now those statistics are completely reversed. And most women who contract breast cancer live with it as a chronic condition for decades. So chronic conditions are just going to become bigger issues as we progress in medical care. So we have to find better ways to deal with them. Now, there's this huge strategic misalignment in healthcare, and it's pervasive. It's in every single community that I've seen in the country, which is that our delivery is organized around acute disease and injury. Right? Hospitals are all built around, we're going to do surgeries, we're going to treat trauma, we're going to do all these things, but most of our spending is coming from chronic conditions. So strategically, we've aligned ourselves around treating what is the tiny piece of what we need to treat. And intellectually, we do the same thing. Most of our research, most of our effort goes into these really esoteric, extreme acute conditions, but most of our patients suffer from chronic conditions. So we need to reorient and align around the reality of where the demand is. Some of the defining characteristics of chronic disease is that, for the most part, they are lifestyle driven. And I'm very careful here in saying lifestyle and not behavior. And those of you students who are here, I would really encourage you to adopt a language of lifestyle, not of behavior. Behavior implies that a single person is doing a single thing, and gee, aren't they really bad? You know, your 4-year-old has really bad behavior tonight because he didn't have a nap. Try rolling that out to a 65-year-old patient. It doesn't play very well. But in addition to being disrespectful, it misses a really important element, which is that the behaviors that drive these chronic conditions occur in a social setting among a group of people. So think about most lifestyle issues. They're communicable. Obesity is a great example. If your parents are obese, the probability of you being obese is dramatically higher. Smoking is another really great example. The most successful smoking cessation programs target entire families or social groups, not individuals. Because an individual who quits smoking but shows up for bowling on Thursday night with the whole group of buddies and they're all smoking is much more likely to smoke than someone who shows up at bowling and everyone has quit. President Stanton told me today that ETSU is now a completely smoke-free campus, and you're pretty close on getting there. If you can make it a smoke-free community, you will have really achieved something dramatic. Cleveland Clinic did exactly that. Toby Cosgrove came in and said, we're going to stop smoking in the clinic. We're a health institution. We shouldn't foster this. And then he said, you know, this isn't really enough. We're going to not hire smokers. Period. And in order to do that, what they did was they went out into the whole community and they offered smoking cessation for free to every resident of Cuyahoga County. In 1 year, they took the smoking rate in Cuyahoga County from the highest in the state, 36%, to the lowest in the state, 28%. Because one institution with the iron will of one individual decided that they could change it. So these things that drive chronic diseases are lifestyles. They're not individual behaviors. And we need to think about them in the context of the social environment where they occur. Chronic diseases are typically complex. We train clinicians to think in terms of organ systems, but we forgot to train the chronic diseases. And so the chronic diseases go across lots of different organ systems, making them, in the way that we treat patients, really complicated. So a patient with diabetes needs a whole lot of different clinician care, and that becomes a big problem in the way that we have it set up. So a patient who needs cardiology and retinopathy and neuropathy issues and diet and exercise needs to pull a whole bunch of different pieces together in order to successfully address this complex condition. And the third thing about chronic conditions is that our treatment of them generally fails. It's a cold, hard reality that a lot of physicians kind of resist at first, but the reality is we're failing at treating them. And the example that I'll give you is type 2 diabetes. Patient gets a diagnosis of type 2 diabetes. The general path is that they're told lose weight and exercise, quit smoking if you smoke. Okay, so that, and then come back and see the physician in a month. They come back, they haven't quit smoking, they haven't changed their eating, and their diabetes is worse. So we put them on an oral anti-diabetes medication. One of the complications of that is that it generally causes weight gain. Weight gain leads to increase in the complications of diabetes. The other thing about the oral medications is that they only last for a certain period of time. It's not a question of when will they fail, or if they will fail, it's a question of when will they fail. And usually it's about 5 years for most patients. When the oral diabetes medication fails, then they go on insulin. Insulin, by the way, causes weight gain, adding to the complications. When insulin stops working, then we put them on insulin together with anti-diabetes oral medications. And when that fails, we start cutting off their extremities. And that's the path for most people with diabetes over some period of time. Our treatments of chronic diseases typically fail. So how do we shift from chronic disease toward the concept of chronic health? This is the point that I made earlier. It is inherently less expensive to live healthy. And so the point is, what we need to do is start thinking about how do we spend early and spend small, as opposed to spend late and spend really big. We can prevent the complications of diseases like diabetes for relatively little amounts of money if we organize our care systems efficiently and effectively. Now, if we're going to have physicians who have done fellowships training patients in diet and nutrition, it's going to be really, really, really expensive. But if we're going to have patients who succeed in diet with their diabetes train other patients, it's really cheap. And I always laugh when there was just a study that came out yesterday that predicts that we'll have 63,000, we'll be 63,000 doctors short in 10 years. And my answer to that is that's just bull. We're not going to be short on, we're not short on physicians now. We're not short on nurses now. We just use them for the wrong things. We have doctors trying to teach patients about diabetes, and most doctors couldn't put a balanced meal on the table if their life depended on it. Why don't we use people who know how to do diet and nutrition to train people on diet and nutrition? It's not only more effective, it's also a lot more efficient. These lifestyle drivers are a big deal. I'll read this because I don't think you guys in the back can. 75% of the country's $2.5 trillion in healthcare spending is driven by obesity, type 2 diabetes, heart disease, and cancer. Most of these conditions are preventable because they are caused by diet, exercise, and smoking. It's pretty obvious these are lifestyle diseases. So how do we effectively treat patients? One is to recognize that health is co-produced. Health is produced between clinicians and patients. And that is particularly true in the chronic disease environment, where patients only see their caregivers for limited periods of time, but they live with their disease all the time. So we have to recognize not that they're responsible. It's not a you have to do this, and if you don't, you're a failure. But it's we have to work together to enable your health. In the context of chronic disease, it's a matter of treating the patient, not just the disease. And if you go back to the example of why traditional treatments for type 2 diabetes fail, it's because they focus on the disease. And we don't have enough drugs to treat all these diseases alone. We have to figure out how do we treat the whole patient. And type 2 diabetes, coronary artery disease, a lot of these diseases are actually reversible if we change lifestyles. This is one of my favorite recipes, French fry Spam casserole. We make it every Thursday. You don't have to write this down, by the way. If you use Gmail, up on the top of it, when you go to your spam file, it'll put up a link that says Spam casserole recipe, and you can just click right on it. I had a dietitian run this through for me. This particular recipe has 1,800 calories. It has 45 grams of saturated fat per serving. 45. I think that's 2.5 times the recommendation. So the question becomes, can you treat French fry Spam casserole? And the reality is, if our patients are eating this kind of food, we're going to fail. So what we need to do is figure out, how do we change the entire lifestyle of patients? And the reason that I bring this up is that every community that we work in, we find some particular food item, particularly in the Southeast, that is a major driver of obesity and diet problems for patients with diabetes. In South Carolina, we were working in Greenville, and there's a restaurant that serves a sweet potato pie. I took a dietitian, we went down, we got the recipe from the chef. 2,200 calories in a serving, and that's dessert. 2,200 calories. And one of the waiters told me that about half of the people who order it have their piece and then take a piece home. So the reality is, if that's what you're combating, you're gonna fail. You don't have enough metformin in the warehouse to take it on. So to do this, what we've got to do is shift our mindset from this notion of we do to patients to we do with patients. The acute care mindset is clearly around do to patients, right? Think about the situation for caregivers and patients in the acute care context. We bring them in the hospital, right? Take away all their clothes, give them a gown that their butt falls out of. We put them on a table. We may strap them to the table, and then we do something to them. And they get better or they don't, but that's how we do it in the acute care context. You can't do that in the chronic disease setting because we can't stop people from going to those restaurants. But we can train people so that when they go to those restaurants, they find the nutritious foods. They find the foods that they can be ordering. They eat portions that are reasonable for a person with their medical condition. But we have to do that with them. We can't do it to them. If you think about chronic disease care today, it's variable and usually unsuccessful. It's expensive and wasteful. And it's complicated and it's poorly coordinated. I, by the way, despise the word coordinated in care. There's a big push for coordinated care. And I think that's ridiculous. Because what that says is we recognize that we have this hodgepodge gamish out there, and what we're going to do is we're going to put another layer on top of it to coordinate it for people. Why don't we fix it underneath? So instead of coordinated, why don't we have integrated care? And then we don't create another level. It'll be a little bit less employment, but maybe it'll save us a whole lot of money. But this is how we do chronic care now, and what we have to do is go to chronic care that delivers solutions for patients. Back to the McDonald's example. McDonald's offers a really efficient solution for hunger. It's not a good one in a lot of ways, but it's a very efficient one. So a solution, I think, has 3 characteristics. A solution has to be effective. It has to work or else it doesn't really matter. It has to be efficient, and it has to be convenient. And in healthcare, we almost never think of the convenience for patients. Now, every single hospital that I go in tells me that they are patient-centered. I've heard that phrase so much that I have almost a barf reaction to it. Here's my test. If you are patient-centered, Why do your patients have to drive 3 laps up the parking garage to get past all the reserved for doctor parking spots? If you're really patient-centered, shouldn't those be for sick people who need to be near the hospital? Let the docs walk. Be patient-centered. How many McDonald's have you ever seen that you can't go through the drive-thru because the employees park there? We do it in healthcare, and we don't even think about it. We park in the drive-thru lane. In fact, we don't just park there, we put up big signs that say, reserved to park here. That's not a solution for patients, and it can't succeed in the long term unless we give patients solutions. My definition is that solutions enable people with chronic lifelong conditions to live in health. So are you enabling them to live in health? And if you're not, then you're not doing it right, and you won't succeed. Elizabeth and I have come up with a framework that we like to use to help people think through this. And this slide that I'll go through represents what we do in a full 2-day seminar. So understand that I'll give you the 5-minute version of it, but it won't quite have the richness of the 2-day seminar. We think first about patients and families. And I would encourage you to think about both of those. Patients generally don't exist without families. And in the chronic disease realm, families matter. Patients who need to observe a certain diet or be in a certain environment can't do that unless their family participates. We deal with tons and tons and tons of patients with type 2 diabetes who say, the biggest problem that I have is that my family has pizza night on Friday, and I just can't stay away from the pizza. That's a big issue. So think about patients and families, and think about them in terms of a group of patients with similar medical circumstances who are going to have similar sets of needs. And here I always encourage people to think of an 80-80 rule. Think of a group of services for which 80% of your patients will need 80% of the services that you're offering, and that it will cover at least 80% of all the care needs that they have for that medical condition. So think of groups of patients. Patients with type 2 diabetes are a really good grouping. Patients with type 2 diabetes and a broken arm is not necessarily a good grouping, because not very many patients with type 2 diabetes are routinely going to have a broken arm. So group them by what are their medical circumstances. Then second, think about what's the team of caregivers needed to treat the full cycle of that medical condition. Not one little piece of it, but the full thing. Think of it from the patient's perspective. If you have diabetes, what do you need? What's the full suite of what you need? So think about what team do you put together to address that. And then think about what is the solution that you offer your patients. Now, step 2 and step 3 kind of bounce back and forth, because as you start thinking about the solution, you think, oh, we need another person over here, or as you add people, you can widen the solution. And solutions will vary. I was talking to some people earlier about the Steno Diabetes Center in Copenhagen. Is a really cool integrated diabetes program. And at the Steno, if you have a foot problem, they will not only treat your foot problem, they can make you a pair of shoes at the clinic. Kind of cool. If you have a really bad foot problem, that's a big issue if you have diabetes. At the Joslin, if you have retinopathy, they can do laser surgery the day of your appointment on the floor below the exam rooms. Right there. Take care of it so that they don't say, gee, Mr. Wallace, we're terribly sorry to tell you that you have this medical condition that could cause blindness, and we'd like you to make an appointment in 3 weeks from now. Go ahead and get that treated. 3 weeks, I'm worried about my eye. I'm going to go blind. What am I going to do? What they say is, Mr. Wallace, you have this condition. We're going to take you downstairs, and we're going to do a laser treatment on it right now. So think about patients, the team, the solution. Then what are the outcomes that you're going to measure? How do you know if you're succeeding? Come up with the outcomes. I will tell you that it really, truly doesn't matter what your outcomes are, because if you start thinking about measuring outcomes, you're going to get better. People get into these unbelievable debates about which measures are we going to use, and are they consistent with measures over there, and da-da-da. It doesn't matter. Measure. Once you start measuring, you will start to improve. The great example of that is thoracic surgery. New York and Pennsylvania required that if you split open a chest, you had to report if the patient died. Now, the docs got together and they said, that's a terrible outcome measure. I personally don't think it is. If I'm dead, that would matter a lot to me. But they were really arguing, and the legislature stuck to their guns, and they said, no, you have to measure this. So the surgeons got together and they said, well, that's just going to characterize us terribly, because it's the inverse of Lake Wobegon. Every physician has the worst patients. I have worse patients than average is the rule. And every physician has worse patients than average. So what the surgeons did was they got together and they said, well, okay, if we're going to have to measure that, then we're going to measure this and this and this and this. And they came up with a comprehensive set of measures. Thoracic surgery now has the best set of outcomes measures of any field of medicine because they started measuring it. And thoracic surgery has improved the most because of those measures. So think about, what are you going to measure? And when you start to measure your outcomes, it enables all kinds of new partnerships. If you're measuring days of work that your patients are missing as a result of their diabetes, I can tell you employers in your community will be acutely interested in what you're doing. And if they're interested, they're probably willing to pay. And they jump into the mix. So think about how to structure in this. Think of a group of patients, the team, what solutions are you going to offer them, what measures are you going to take to know whether you're doing well, and then how can you start to add new partnerships to it. Now, this is maybe my favorite slide. I'm kind of a geek that I get really into having PowerPoint slides. But if you get a diagnosis of diabetes, this is what you're supposed to do. You're supposed to coordinate your care in this little honeycomb. And if you don't take on this task, you're non-compliant. So think about each one of these probably represents a half day off work, a copay, parking fee. Somebody's got to take care of the kids, right? All of the things. And then, by the way, you've got to coordinate the information between all these people because they don't have an electronic health record system that's going to allow them to communicate. And do we wonder why patients don't succeed? Who could possibly do this? And yet, we have 35 million Americans who are supposed to be doing this. This is the system that the Joslin created that I mentioned before. In one day, you're there for 4 hours. You go through on one floor. They have on-site labs. What a concept, right? You are actually, as a clinician, going to have the lab values for your patient at the time that the patient shows up. It's really revolutionary. You get an eye exam. They have an endocrinologist. They have a nephrologist. They have diabetes education. They have mental health. All of these things are all together. And the patient makes one appointment. And the team works together. And the team reports together. And Joslin is so advanced that they now have 4 different teams. And they concentrate not just on patients, but they concentrate on subgroups of patients. So they have one group at Joslin that treats Spanish-speaking patients. Everybody on the team speaks Spanish. Makes it a lot easier, right? They have another team that deals with patients who are pregnant. They have one team that that handles everybody with a device. So if you've got a pump, you're in this team. Think of the depth of expertise that these people develop, because they're working in a team and they really focus on a group of patients. People think that if you select a group of patients, you're narrowing, but you're not. You're deepening. You're really deepening your expertise. Now, this is a slide that we created tracking the experience of two people that we know, 2 women about the same age, diagnosed with breast cancer right about the same time. Turns out that each woman had not just the same type of breast cancer, but the same subtype of breast cancer. They were in a community that views itself as working as a team. The clinicians in that community view themselves as a team. They have each other's phone numbers on speed dial. They talk to each other all the time. You know, you can see them at soccer games and stuff calling each other. They're in their car calling each other. They think that they're a team, and they think that they're working together. So here was the path of the first one of our friends as she went through. She started with the medical oncologist. And just, you can fill in what all the different medical, surgical, da-da-da-da-da. That's the path. Now remember, she's having to create this, and she's having to set up all these appointments, and she's having to track all this information. Our second friend, same subtype of cancer, same age. I mean, these patients are as identical as you can get two patients to be. This was her path. It's a hard thing to do in a crowd that has a bunch of young students. We refer to this as patient pong, because the patient's bouncing all around like the old-fashioned pong game. My kids, by the way, think that that's a stupid game, and I think that they're really stupid kids when they say that. It's a very sophisticated game. It required a great deal of skill and talent to be good at it. I'm just, as an aside, I realize that's not part of tonight's lecture. But that's patient pong. That's what we do to patients. Now, clinicians in the room, stop and think about this picture for a second. Think about those two patients, and if you were any one of those clinicians, think of the different information that you're getting about that patient at the time you're making your care decisions. In the US, in every community we go in, every community has a tumor board, and they meet before patients go for surgery. Almost none of them meet after patients come out of surgery. How'd we do? Were we right? We don't know, because we don't measure. We don't check. But the other thing is, we force patients to create a care path when they don't have to, because we know what those patients are going to need. If you look at MD Anderson and their cancer center, they now have compressed this process to 2 days for women who come in with a primary diagnosis of breast cancer. They start their treatment program in 2 days. And think of not just all the time and the money that's saved, but think of the mental anguish that those women avoid who don't have to go through this. This is a different example that we use. This is in one of our case studies out of the Harvard curriculum. It's of an insurance company in Germany. A little bit of stage setting for this. In Germany, the insurance companies pay your employer if you miss a certain number of days of work. And so the insurance companies have an incentive to get employees back to work. This particular insurance company, and I love this name, this is, I don't know if you can see it way in the back, but it literally is as long as my arm. That's the name of the insurance company. So next time you think Prudential Insurance Company of America sounds long, think of that one. But this company started looking at migraine, and they realized that they had a huge expense from migraine. On average, their insureds missed 11 days of work with every migraine incident. And the way that it was set up looks a lot like our patient pong. Patients with migraine generally have one of three causes. It's either neurological, it's physiological, something to do with their posture or how they're sitting, or it's psychological or drug-related, things like that. So what happens is typically patients that have a migraine go see either a neurologist, a physical therapist, or a psychologist. If they guess wrong, their condition isn't related to that one condition, then they have to start the whole process all over again. And they have to do it in the middle of a migraine episode when standing up is difficult. Is it any wonder that it's an inefficient process? So what the insurance company did was they recreated the system, and they put neurologists, psychologists, and physical therapists all together. Patient comes in and is seen by all three at the same time. And the three of them get together and say, I'm pretty sure, Dr. Stanton, that this patient is yours. This looks like it's neurological. Can why don't you take the lead on this? Or they say, no, this patient clearly has a psychological issue. That's mine. And the patient gets treatment much more effectively and much more efficiently. Great statistic out of this. They reduced the number of patients missing, the number of days that patients miss work with a migraine incident from 11 days to 6 days. That's 5 days of not having a migraine. I mean, I don't know if you guys get migraines, but if you've ever been around somebody with migraine, 5 days of migraine is just a short burst in hell. And they're eliminating 5 days in 1 year. Interesting data that came out of this. 18 months into their program, their cost in treating patients in this program were significantly lower than in the other. So now, not only have they got a better outcome for patients, they've also saved money. So if we think about redefining treatment, redefining care delivery, we go from individual diseases and a focus on facilities and a treating conditions, treating diseases, measuring the volume of service and cost shifting, and we've got a whole new paradigm that we can look at. Instead of individual diseases, we think about patients with common occurrences, co-occurrences. We're not going to treat everybody with a belly button. We're going to treat patients who have this set of medical conditions, because if we focus there, we can really deepen our expertise. We're going to go from focusing on facilities to teams that coordinate and integrate their care. A team that works together and talks together and learns together and measures outcomes together. We'll go from treating diseases to creating solutions for patients and families. We'll go from measuring the volume of services to measuring the value of services. Did we make our patients better? And we'll go from cost shifting to partnerships that link payment and value. You know, there's a big debate in the US about bundled payment. Oh, we need to go to bundled payment. We need to get away from episodes of payment. We can't really do bundled payment until we create teams. Teams getting together can allocate payments very, very effectively, and it's better for patients. So let me now, this is my absolute soapbox speech on compliance and capabilities. Compliance is where we are right now. Compliance is that patients do or don't do what they should do. Should is always, you have to, if you say should, you have to have your finger out, because it's what they should do, and that's how we treat patients. There are so many statistics on this that you can go blind reading them all, but 1/3 to half of all patients fail to comply with their physician's orders regarding drugs. I mean, all the physicians in the room are going, yeah, that's right. You know, Bill Clinton was the poster child of noncompliance for a while. There are myriad others. Why? Why is it that patients aren't doing that? Why aren't we succeeding? I think it has to do with this focus on compliance, that we're trying to tell them to do things, but we don't tell them necessarily why, or they're not motivated in why. So how do we go from compliance to capability? The starting point is to recognize that compliance only matters if it improves a patient's capability. The reason we want patients to take meds or to do certain things is so that they get better, so that they can do things that they want to do. So if they're not doing the things that they're supposed to do, they're not going to be able to do what they want to do. Or conversely, if they do what they're supposed to do, it's so that they can do what they want to do. Oop, you hit the wrong one again. So how do you start to get there? Well, the first thing that we always focus on is, what's the lowest patient threshold? What can the patient do most easily? I'll use type 2 diabetes because that's where I spend most of my life. Most patients with type 2 diabetes, and I say most because statistically it's more than half, smoke. Smoking is a really, really, really hard addiction to break. Most patients with type 2 diabetes have some sort of eating issues. They are overweight. Most patients with type 2 diabetes are inactive. Those three things tend to go together. So out of those three things, what are we going to have patients do? Well, if you go in the doctor's office, they give you a list, and they say, start exercising, eat better, and quit smoking. Oh my gosh, that's overwhelming. I can't possibly do it, so I'm not doing any of it. How about if instead we say, what we'd like you to do is walk to the end of your driveway and back every day. And if you can do it really comfortably once, try and do it twice in a day. And if you can get up to doing it 3 times in a day, maybe try to walk around your block. Kind of like lifestyle and behavior, don't talk to patients about exercise. Talk to them about activity. Exercise implies some skinny little person I'm not allowed to use that word, I forgot, I'm on camera. Some skinny little person in spandex who goes to an aerobics class and uses weight machines that look like torture devices if you don't know what they are. Somebody who is overweight and is kind of gym phobic is not going to do that. They're not going to exercise, but they will become more active. And even very small changes in activity will lead to weight loss in most patients. So if you can get them more active, all of a sudden they start to lose weight. And then they come in and they say, I'm losing a little bit of weight. I'd like to lose more. Now we've got an opening. We've got another low threshold. And it's only after they're exercising and losing weight that they can possibly think about smoking cessation. That's a really, really hard one. So start with the easy stuff. I always say, get rid of the lowest hanging junk food. It's the easiest. And then finally, it's not all about sacrifice. How do you make some of this fun? How do you make it interesting? Cleveland Clinic is a great example. They did a Biggest Losers competition within the hospital system. They lost 56,000 pounds. If you think about it in a sort of anatomical way, it's disgusting. But if you think about it, they actually ran the numbers on it, and a pound of weight loss is worth $50 in their benefits plan. 56,000 times 50 is a really big number. It matters. But it was fun. They had a big competition. They had prizes. They were giving away awards. It was in the newsletters. Everybody was talking about it. They made it fun. This was in the local paper. I was down in Florida. It was in the paper there. Hula hooping classes. Big deal with the over 50 crowd. They got all these people into a room and they started doing hula hoop. You know what? It's activity, it's movement, and it's fun. It doesn't have to be about sacrifice. You can make it fun, and if it's fun, it's more sustainable. So this notion of capability is, what does a patient want to do? I want to walk down the aisle of my kid's wedding. We got a huge insight on capability working in South Carolina, interviewing patients about what were they most afraid of losing with their diabetes. Big, burly, tire manufacturing guy, 58 years old, big tummy, pump on his hip. This guy was not succeeding with type 2 diabetes. Started asking him questions, and he was a gruff, tough SOB. I mean, just really, you know. And we started talking about, what are you afraid of losing? And he teared up. And he told this story, and I still have a hard time telling this story. He said, my grandfather taught me to hunt. And my dad taught my son. And my grandson's 7. And I can't take him hunting because I can't walk well enough in the woods anymore. And I relayed that story to one of the physicians, and he said, that guy's my patient. And I said, wow, that's interesting. Why aren't you succeeding? What's happening? He said, I can't get that guy to do anything. Sounds like you got an opening. 3 months later, he came back and he said, you remember that guy, the hunter? And I said, yeah. And he said, he's 35 pounds down, and he's walking 1.5 miles a day. And this fall, he's going to take his son deer hunting, his grandson deer hunting. That's capabilities. That's what works. The guy didn't care what his HbA1c number is. I'm not sure he could spell HbA1c. And I'm completely certain he doesn't care if he spells it, but he does care about taking his grandson hunting. So tie it to what the patient cares about. You know, the simple question, what moves you? Because that's the starting point for capabilities. All right, the last thing is from deeply emotional to coldly analytical. Talk a little bit about strategy. My colleague Michael Porter is the father of modern strategy theory. I mean, Mike literally wrote the book on strategy. And Mike has a great paper that you can get actually on the web called What is Strategy? I figure it was pretty clear what he was writing about. And Mike identified 3 things that are crucial in a strategy. The first is, sorry, I got ahead of myself. The point is, we don't have strategy in healthcare, so let me go through some things about strategy. The first of Mike's observations is that strategy is about unique value creation. And apply that in the healthcare delivery setting. Is there anybody anywhere who does anything unique? We compete in healthcare on the basis of similarity, not on the basis of uniqueness, right? the guys down the street got this fancy-dancy MRI, so we got one. We have an MRI now. See, we have one that's as cool as theirs. We can do all the same little pictures they do. You should come see us. They deliver babies, we deliver babies. They cut off feet, we cut off feet. We do everything they do. You know how hospitals compete? Who has the best lobby? There's nothing unique in the way that they deliver their services. There's no unique value proposition there. So what do you do uniquely well? What do you do that other people can't do? What do you do better than other people do? Focus on it. Build on it. That's where people can drive now. They can go more than 10 miles to get their health care. Define yourself by what you do uniquely well. Second part of it is fit and consistency. What are all the things that come together to create the unique value that you deliver? Is it the parking lot? Is it the hospital gowns? Cleveland Clinic just spent a ton of money and redesigned hospital gowns. Sounds like kind of a silly thing, but if you're going to live in a hospital gown for 2 weeks, it'd be really nice if it covered your butt when you walk down the hall. They got Diane von Furstenberg to come in and work on the design with them. It's a really cool, I mean, what a great idea. So it's fit and consistency. It's all the pieces that go together. You know, outside of healthcare, think of it in the classic example is Southwest Airlines. Think of all the things that make a unique value proposition for Southwest Airlines, right? No assigned seats, no meals. But what they do is they get you there on time and cheap. All their activities go toward the unique value of getting you there on time and cheap, and they fit together, and they're consistent. And then the third thing that Mike talks about is trade-offs. You can't be everything to everybody, because if you are, you're nothing to everybody. So what things do you not do? Inherent in making a decision about what are you really good at is coming to terms with what you're not good at and letting other people do that. And clinicians should do that individually in their practices. If you measure your outcomes, you would know that with this group of patients, you're really good. Or with this medical condition, you're really good. And with this one, you're not. So either get better at it or let somebody else do that because that's not what you do well. Trade-offs are seen in healthcare as a statement of weakness, and they're not. Making trade-offs is a statement of strength. It is, I'm going to choose to do the things that I can do really well. Now, those are Mike's 3 observations about it. My colleague Elizabeth Teisberg made a 4th observation about how do you know that it's a really good strategy? And Elizabeth's point is that a really good strategy feels like a cause. If you think about companies where they have a really good strategy, the people who work there are nuts. I spent some time with a whole group of people from Google. They drive you crazy. They're like, Google this, Google that, da, 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 da. They're all hyped up and they're excited and they're da, 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 da. You ever see that in healthcare? You see the nurses running to get in the morning because they are so pumped up because we do this better than anybody else? Having a good strategy, being uniquely good, becomes an enormous source of pride. In talking with Randy today and in talking to different people around the university, you know, one of the things that ETSU does uniquely well is this blending of pieces. Philosophy together with medicine, theater together with business. All these pieces that you put together, that's a unique value proposition. That's something that you do, and the people who participate in that are really proud of it. So find the things that you want to do, that you do well, and focus on those, trade off the other ones, and it becomes a rallying point. It becomes a cause for people. So it's my sense that a health strategy is a coherent set of initiatives and activities that improves the healthcare and productivity of employees or patients or whatever group that you're looking at. For those of you in the group who are employers, employers need a health strategy too. How can you ensure that your employees are healthy and productive? Come up with a strategy around it, and it makes a big difference. I will have these slides available to Randy in a PDF so you guys can download them, but my contact is there if you want that? Or I can, if you give me a card later, I will send you those. And I think, Dr. Stanton, that concludes my comments.
What a great presentation. Scott has agreed to answer some questions.
Only if they're easy.
Dr. Stanton's here to answer the hard ones. Yeah. I'll go to Dr. Curry and then.
Amal Khoury from the Department of Health Services Administration. You
got to hold it right there or they won't hear you. There
okay.
You go.
You're very passionate, and about describing an integrated model of care, and you provide, strong evidence for that. I would argue that one of the main barriers that we face as a nation in promoting this model is the incongruence between our payment systems to providers and integrated care. Our payment systems have traditionally and continue to some extent to support episodic care and doing to patients. You mentioned bundled care. We're starting to see baby steps perhaps in that direction, but I was wondering if you have additional thoughts about that and how fast do you think our payment system would catch up with our strategy as you defined
Yeah,
it?
two quick thoughts on that. One is that, and I will say this cognizant of having been introduced as a director of the Blue Cross plan in the state and in the presence of another director, if you wait on the plans to get there, it's never going to happen. And there's some defense for that, actually, because the plans don't know how to pay something that doesn't exist. It is quite possible, though, to go the other direction, which is to bundle the services, bill for it on per encounter basis, pull those payments and redistribute them. Hospitals are fully capable of doing that. A number of hospitals are doing that now. Geisinger in Pennsylvania is one example. And so the first response on that is that's the responsibility of providers. Give people something they can pay for in a bundled sense. And you can start small. You don't have to be comprehensive on everything. But some of the things that you can bundle the services around routine surgeries, hip replacement, knee replacement, CABG, the ones that you do a lot of that you know what those expenses. You can get smart actuaries and you can figure out a bundled cost on those. The chronic conditions are actually easy in a sense that they involve less expensive resources. So to create an integrated practice unit for diabetes, you don't need to have a lot of really expensive doctors and nurses. You can do it with a lot of other kinds of caregivers, so the cost is a lot lower. So my first response is that's the starting point of providers, because unless you create something that people can pay for, they don't know how to pay for it, and they've got a legitimate argument in that direction. The other piece of it is start small. Just start doing some stuff, and you'll see that it really does work. And the piece I would add to that is talk to employers. One of the things that we found in building these integrated practice units all around the U.S. and now internationally is that providers are acutely interested in that, and they're willing to put money into it. The project that we were doing in South Carolina, we're working with Michelin, the French tire company, and Michelin did a really careful analysis of their spending, and they said, we spend this much money on acute care and this much money on preventive care. We're willing to gamble for 2 years that if we increase the spending on our preventive care by a factor of 4, that we might get a reduction of 5% in our acute care. And if we did, we've got a home run. In fact, I think their numbers were, we can increase our preventive spending by an order of magnitude, and if we get a 10% reduction in our acute care, we've made a ton of money. So all of a sudden, Michelin was willing to come in and say, we'll put in money toward a bundled system for our patient, for our employees, and we'll see where it goes. And the cool thing about working with an employer is that you can start small without using up a lot of money, and then when it works, you can expand it. You probably can't make that same offer for the TennCare program right now, but you could make it for employees of a major employer here. Now, one response that I get a lot of times from hospitals is they'll say, well, we're the largest employer in our community. We wouldn't know who we would go to. And you sort of sit and you count, and you wait, and somebody invariably starts to smile and they say, oh yeah, if we're the largest employer, we could probably do it with ourselves, and it's pretty easy to negotiate if you're on both sides of the table. So my response is, start with providers, look for employers.
Hi, my name is Ariel Cintrón-Arias. I'm a professor of mathematics and statistics. And I'm trying to understand the problem of the lack of electronic medical records. I'm trying to understand and make an analogy in my mind, and I just wanted to ask if this analogy is fair. So, especially when you show that flow chart and you talk about that patient that has to go from one bubble to the next, carrying out all these records, it makes me think of the credit report and the credit scores. It makes me think, how would it be if such thing as the credit report didn't exist? And if every time I have to go to a lender or a financial institution, I have to carry out a history of all the bills I pay, or I have to have my friends write a letter saying that I'm a good payer or something. Do you think that's an analogy?
When I started doing the health IT stuff, now it's not going to stop. Okay, there. I worked with an HHS secretary who I won't name, who we were briefing him, big, thick briefing books. If you ever in the HHS building, it's pretty funny. And candidly, he was falling asleep. Well, I think he was pretty sound asleep. And we got into the point of electronic health records, and he pops up. And he said he wanted to be the Secretary of Transportation, and he had installed a whole bunch of toy trains in the wall. And he pops up and he says, "This is just like the train problem." And we're all like, was that a dream, or are we all together here? And the point was that there was this analogy that everybody liked to use of in transportation we had different rail sizes. And they'd have to stop a train at one place and unload it onto the next train because the two rail sizes weren't consistent. Boy, that's the analogy that's going to work in healthcare. And we went through about 600 really simplistic analogies. The bottom line problem in health IT is that there is not a health orientation in care delivery. I spent a lot of time and wrote a really great federal report that said that the problem in health IT was a lack of financial incentives. And that's just not true. The problem is that if everyone in the system were oriented around the health of individuals, the health of their patients, we would have electronic health records, because it dramatically changes the opportunities to create health for patients. In the ERA bill, the Recovery Act bill, there's $22.5 billion in funding for health IT. I think that it's unclear at this point, and I'm inordinately proud of that, because the language that they used in that bill was exactly what we wrote for a Republican administration that wasn't willing to put any money into health IT, and they just bounced it over. I'm concerned that without changing the way we deliver care, we will install a lot of very expensive IT systems that will allow us to spend money a lot faster. So far, most of the big health IT installs that I've seen have been justified on the basis of providers' ability to improve charge capture. And that's just abjectly perverse. But it's true. That's where we are at the moment. I think that we have some technological issues in health IT. They're de minimis. There are a lot of people running around saying that the big challenge in health IT is privacy. I think that that's just an absolute red herring. I spent a ton of time in New Orleans right after the storm. One of the stories I will never forget, talking to a friend of mine who's a pediatric oncologist, was treating a child who they couldn't find the treating oncologist from New Orleans. He was in Houston treating this kid, and he said, I had about a 3-hour conversation with the parents trying to figure out if the solution that they gave him last time was green or was blue, because the pediatric oncology protocols are extremely rigid. They're very careful. All this kid's records were washed away. They were paper records in the basement of the hospital. They were all washed away. And whether that kid was going to survive or not had a whole lot to riding on whether the parents could remember whether the last solution was green or was blue, where that kid was in the care protocol. I would submit to you that that kid really didn't care about the privacy of his health records. And in fact, I think most of us don't care in a generic sense. Privacy is the wrong word to use in any case. Privacy is you don't want anybody else to know it. And in healthcare, we're not interested in privacy. If I want to see Dr. Stanton, I'm going to show him, whatever he wants to see. I'm going to tell him whatever about my health that I need to tell him. I'm not trying to keep it private. I'm sharing it with him. What I want is confidentiality. I don't want him to tell you, but I want to tell him. So we need to guard confidentiality, and there are ways to do that. But I don't think patients are nearly as obsessed with confidentiality as they are with improving health. So if we could show them a health benefit of this, I think most patients would go for it. There's a remarkable parallel if you look at online banking and online transactions. And if the students in here are like my kids, you can't imagine a time when you couldn't order a book on Amazon. But there was, actually, a really, really long time ago. And when e-commerce was first coming out, there was this big concern, I can't put my credit card online because it'll get stolen. Well, roll the clock forward by 15 years, and guess what? Credit cards get stolen all the time. And we deal with it. People take that risk because they get this enormous benefit from buying their stuff from Amazon or wherever else. And so the parallel in health IT context is if we can show patients an enormous benefit of electronic records, they will be much more accepting of them. But I think that the problem is really, it's not an economics issue nearly as much as it's an orientation issue. If we're not oriented around health, then we're going to play all kinds of games about who's paying what for what. And I'm not terribly optimistic that we're going to make a huge dent even with the $22 billion, which I realize sounds cynical, but.
Well, I can understand Dr. Stanton's enthusiasm with you, Mr. Wallace.
Thanks.
It's very impressive. I'm Dr. Miller, Jerry Miller, 43 years a family doctor. And I started a group 30 years ago called the Holston Medical Group. And today we have 160 providers, multi-specialty. We have 28 mid-levels. We have 4 PharmDs. We have CDEs, dietitians, and so forth. I wish you had another hour because I believe if you did, you would tell me why my group isn't sustainable. For example, no way do I get paid for these PharmDs. No way do I get paid for these CDEs. And I have a program called Integrated Health Services. This is a multidisciplinary team that treats patients. We have just been granted a medical home, patient-centered medical home. We've been doing it 12 years. We've had a fully implemented EMR for 13 years. We see close to 50,000 visits a month. We have 178,000 virtual patients assigned to us. Let me tell you, my cash on hand in Holston Medical Group in 2 years has gone from 36 days to 2 days. It is not sustainable.
Right.
Now, I disagree with you totally on a few things. The real problem with Holston Medical Group is not the patient, it's not the provider, it is the bureaucracies from Washington and the 133 new ones that we're just creating. My Medicare population alone, and it's huge in this region, the oldest population in the state, if I get the SGR cuts coming on Medicare, That's $127,000 a month to my group. Right now, for a 99212 Medicare visit to my group, I am getting reimbursed the same amount that I was reimbursed as a family doctor in 1970. Do you know how much the overhead has gone up? Now, another thing, you talked about
well, let me jump in so I can on the staffing thing. What we've found, and it doesn't work in every setting, but we have found in a lot of cases, adding other services can become more effective, cost effective, if it allows physicians to do what physicians bill for. And so one of the things that we do when we set up the integrated practice units is we ask all the physicians, we give them a sheet of paper. We say, write down everything that you do in a day. And then we give them a pen, a red pen, and we say, okay, now circle the things that require an MD, either by law or by custom. And it's about 5 or 10% of the things that they do. And so then what we do is we take their sheet and we hand that to the nurses. And we say, look through all the things that aren't circled, and then make a list of all the things that you do in a day. And then in a different color, circle the things that require an RN. And then we take that and we hand it down and down and down and down. And if you do that in a comprehensive way, what you find is that you can actually use physicians to do medical work and use nurses to do nursing work and keep moving it down. And what that allows in these groups is that our physicians have much more billable time that they can get reimbursed for. I won't, and never have, defend the existing system. I think it's flawed. I think that the solution to it comes in part in payment reform, but comes most fundamentally in care delivery reform. And if we reform care delivery, we then open up an opportunity to dramatically change payment.
Okay, direct me. I like the value formula that you've got right up here. And we'll start on the bottom. My group last year saved payers $181 million. We can quantify it. Now let's go to the top. What about quality? Of my 14,600 diabetics, 30% reached the HEDIS requirements. Nationally, it's 12%.
Right.
If I look at my admits per thousand on Medicare...
And in the state of Tennessee, by the way, it's about 6.5.
If I look at my admits per thousand, they're the lowest in the state of any group. If I look at my length of stay, lowest in the state. If I look at my readmits per thousand Medicare patients, it's not 23% like it is nationally, it's 9%. We're 97% generic prescribing. And one other point, Blue Cross Blue Shield came out with an article not long ago that the patients get on an average of 18.3 new prescriptions a year. Not in Holston Medical Group, it's 4.2. Now you see, we have a code of conduct for all of our providers, which addresses just what you said. But it's unsustainable, Mr. Wallace. I am 17 doctors short today. I don't know what we would do, basically, if we didn't have the mid-levels. And value, yeah, in our integrated services the other day, this little gentleman came up to me. I walked in and I said, take your diabetes here and live healthy with it. They really know. There's a dietitian and so forth. He follows me out and he says, Dr. Miller, I want to thank you for this program, and cries. He says, I lived down here in the county disabled for 7 years. Get in my car and drive down 7 o'clock and get my newspaper. Drive back up. 10 o'clock my mail. Been coming to this program 6 months. I've lost 70 pounds. My A1C is 6.9. I want to go back to work. So the truth of the matter is, and you're on target, a 10-minute office visit paying me $24 on Medicare cannot sustain or provide the education. So I want to say just one other thing, and pardon the editorial, okay? But I can tell you there are shortages of physicians. 197,000 mid-levels, the fastest growing unit. If you look at the number going into family practice, and I understand why, they don't. I'm one of 43 years. But there are solutions, and we've got to certainly do something with this payer system, yes. With our education system, yes. And my new pillar of medicine is CEC. CEC, not art, science, business, or technology. It's CEC. It's collaboration, it's education, 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 and connectivity. Get rid of this competition. So pardon for the editorial, but I've enjoyed your comments.
Good, thank you. I don't think there was another question there, so we'll see if there's another one out.
Mark Lockett, your honeycomb pod system, you've given us like the Joslin Center at MD Anderson work great for their specific diseases, but that also creates its own pod system. If I had breast cancer and go to MD Anderson, I can be seen by everything and have everything done in 2 days.
Mm-hmm.
But what if I need a screening colonoscopy? What if I have chest pain? I've got to go to a different pod. It may be heart disease pod, GI pod, diabetes pod. Those individual pods are very efficient. But to be able to sustain those pods, you have to have enough patient flow, Jocelyn, MD Anderson, to be able to do that. That means you've really got to regionalize the care for the individuals. So for the state of Tennessee, if you have breast cancer, you might have to go to Vanderbilt or UT Memphis and not be treated here. We know patients do better if they're with their families near home. How do you address that income?
A couple different things on that. On the point of how do you integrate or how do you manage the different groups, what we find is that, and I'll use Cleveland Clinic as an example. Cleveland Clinic does everything by teams. And the integration, so a patient who is in one team needs the services of another team. What happens is that the nurses on those 2 units connect. And so rather than trying to connect all of these people to another group of people, you've got a one-to-one connection. I don't have it in this deck, but if you think of four groups, you then end up with a set of lines that connect those 4, which is a much shorter group of connections than you would get trying to connect all of this. So if you integrate into teams, you lower the number of nodes in the network is the way the math works out. On your point of regionalizing, yes, I'm an enormous fan of that. One of the great statistics that Elizabeth and Mike have in their book is the 1-year survival rate for patients who've had a heart transplant. Now, 1-year survival rate's not a perfect measure, but it's a pretty good measure. If you're dead in a year, you probably weren't as happy with the heart transplant as if you were alive in a year. And so they looked at the variability of 1-year survival rate between the best institutions in the country and the worst institutions. Anybody want to hazard a guess on the 1-year survival rate? And this is 2004 data for heart transplants at the best institution in the U.S. What percentage? Just guess. You're sitting up front.
I have no idea. I'm guessing they were both the same.
Okay, and what would you guess they were? 80%. 80? Okay. And at the worst, if you were guessing, people tend to say, 40, 50. So the 1-year survival rate at the best institutions, there were 2, was 100%. And interestingly enough, that's not risk adjusted. One of those institutions was the Cleveland Clinic that draws pretty much the most difficult cases in the world. 1-year survival rate was 100%. The 1-year survival rate at the worst institution was 0. They were 0 for 6. And I like to point out to people that 7 is a lucky number, so maybe you could be lucky number 7 and go there. The point of it is that if you have a serious medical condition, and I'm not talking about a screening colonoscopy, I'm talking about a serious medical condition, it is not only more effective, but it's also less expensive to fly a patient and a family member there. In the case of MD Anderson, they have an arrangement with Shell Oil that if you work for Shell and you are diagnosed with cancer anywhere in the world, they will fly you and at least one family member to MD Anderson for your treatment there. It is in fact true that patients do better in proximity to their families, but it is also true that you can accommodate families. Another example of that that's really tremendously effective is Cancer Treatment Centers of America. They get a bad rap because they're a for-profit business, but they are tremendously effective in long-term treatment of patients. And at every CTCA facility, they have a hotel affiliated with the organization, and they accommodate families there. And they do something else that's really interesting. They provide family dining areas. And in some of them, they also provide kitchens so that you can fix. But what really blew me away when we did the tour there was they assign a dietitian to every family that comes in for treatment, and they will take your recipes and prepare your food for you so that you have from-home food, getting exactly to your point of people want to be nearby. I think that regionalization absolutely makes sense for the most serious of medical conditions. I think the focus on particular groups of patients with similar medical conditions makes sense for anything that people are doing. If you use screening colonoscopy, people who just do colonoscopies have a better success rate in identifying and also a higher productivity rate. So that grouping does work. And you know what we've done in the U.S. is we've created this series of small hospitals with the idea that every hospital is supposed to do everything. And if you don't, then you're inconveniencing patients and you're not serving your community, and on and on and on. What we don't think about is the flip side of that. If you do everything but you don't do anything very well, or you do everything but you don't do a whole bunch of things very well, are your patients really better off? And I think that's something that we ought to have data. We ought to have outcomes measures and give people a choice. The data that exists so far is that patients, even patients without means, will get transit to get better outcomes.
Just realize you're talking about moving people over the entire country to be able to treat all of these different things.
Right, but
there's an enormous selection bias for the places that you're talking about. The people that go to Cleveland Clinic, that go to MD Anderson, not everybody can be flown by Shell to those places. They're outstanding institutions with outstanding results, and we should all try to be like them. But that access is not available.
I completely agree with you that not everyone has access. The way we will broaden the access is by broadening centers of excellence. So that if instead of every community hospital trying to do everything for every patient, they get together in a group and they say, look, we're going to deliver babies, you do heart bypass, you guys do hip replacements, you then can concentrate the numbers enough. You know, we have surgeons in the U.S. that are doing procedures once a year. And I can't imagine that they have sufficient competency doing a procedure once a year. Whereas if they go to academic medical centers, you will find people who do that same procedure 5 times a week. I just think that there's a huge benefit to doing that. And will there be a transition? Yes, absolutely. But if we move from every hospital trying to do everything to hospitals focusing on what they do well, I think we do have enough of a population to distribute. And I use the example in primary care as well. You know, the same primary care physician that I see also sees my 74-year-old mother and my 14-year-old daughter. And I can tell you that the medical needs of the 3 of us are kind of different. In fact, I think the only medical similarity between the 3 of us is that we each have a belly button. And yet, we're all seeing the same primary care physician. That group has 11 primary care doctors. There's no reason that they can't concentrate their practices. One person take, you know, either geriatric patients or women over a certain age. Another take men my age. I mean, you can do this in a way that makes a lot of sense even within the existing system. It's being done all over.
Well, thank you, thank you, Scott. I know there's some other questions. I think Scott has said he'd be willing to stay around and answer some questions privately. Scott, we do have some parting gifts for you, but I did want to say that,
is it sweet potato pie recipe?
Every now and then we have a lecture where my take-home message is I feel sorry for the people that weren't here, and this is one of those lectures.
Oh, thank you.
Really appreciate it.
Oh my gosh.
better than a sweet potato pie recipe is the Encyclopedia of Appalachia.
Oh, that's cool.
And we will mail these home to you. You don't have to carry them on your take-home.
Okay.
But you do have to take it right now.
Thank you.
But wait, there's more.
This is like NPR, with the quiz. My mother's from Kentucky, and I spent most of my childhood in Kentucky, so having an Encyclopedia of Appalachia is a really meaningful thing.
And this is an award that's as much an honor for us as it is for you, but we'd like to bestow upon you the status of honorary professor in the College of Public Health.
Wow. That's very cool. Thank you.
Thank you very much.
That's really nice. Thank you.
Well, thank you, and it was a wonderful lecture. And just to remind you all, the next lecture in our series will be November 16th. Dr. Carlos Castillo-Chavez will be talking about public health policy and national security, life in the times of emergent and re-emergent diseases, and we'll be co-sponsoring that lecture with the Department of Mathematics and Statistics. And again, another example of just bringing everyone together. So look forward to seeing you all then. And Scott, once again, thank you very much.
Thank you. Oh, that's good.